ERCP it's one of the best and most rewarding procedures. I think every interventionalist loves ERCP, loves pus drainage. We love the wires and all the devices.
Pus drainage.
Everybody loves pus drainage. It can also be, very frustrating and humbling procedure. And I think, what I love about it is the challenge. You never know what you're getting into. Be a straightforward stone case and be a nightmare to cannulate or whatever. So it's always a challenge, and that's what I love about it.
Hi, everybody, and welcome back to another episode of EndoCast. I'm your host, Leslie Bishop, and this is episode 21 with our physician guest, Dr. Jessica Widmer from the NYU Long Island School of Medicine. EndoCast is a GI-focused podcast for clinicians, by clinicians, presented to you by Boston Scientific. Together, we'll take a closer look at the data, techniques, and insights of endoscopy that matter most to listeners like you.
Dr. Widmer, welcome to EndoCast.
Thanks for having me. I'm excited to be here.
Yeah, thank you for taking a little time out of your DDW crazy schedule we were just talking about. Hopefully this will be a nice fun break from the all-day events you've been doing.
Yeah, definitely.
So tell me, I know we're going to be talking about ERCP, but I would love to hear a little bit, I'm sure the audience would love to know a little bit about you, and maybe how did you get into GI? Why did you go into medicine? And maybe why even therapeutics?
Okay, well, I guess that's a long story. Since I was a kid, I always wanted to do medicine. I thought being a heart surgeon sounded really cool. But by the time I got there, that wasn't really my interest. And I kind of stumbled around to gastroenterology. And I guess it's a funny story and maybe brings up women in medicine, because when I started rotating in gastroenterology, there was one really great female physician who really took me in and tried to get me included, but she was in motility, and she would say, I have the perfect patient for you in my clinic. And, at the same time, my heart was sinking, and I'm thinking, oh no.
You weren't interested in motility.
No. So it turned out that she took a job somewhere else because her husband was relocating. And, one of my future mentors came who, thankfully guided me towards advanced endoscopy. And that's how I ended up here.
Okay, I love that. It's interesting. We've had two doctors now who said they knew they wanted to be doctors when they were little. I think that's kind of amazing.
I have no idea why. No one in my family is in medicine. I thought it sounded good. And I guess I don't know. But then my interest, through high school and everything was science and biology. And, my friends were in study hall and I was dissecting animals in a bio lab.
Come on.
Yeah.
What was your favorite dissection?
Probably the most memorable was a cat, because I just,
yes. You dissected a cat?
Yeah.
I will not tell my cat buddy. I don't think he would like to know that.
Yeah. So that was just my interest and just worked out.
Talk to me about your current clinical focus.
I do all advanced endoscopy, and I guess my focus is really pancreaticobiliary work, GI malignancy, and my area of interest is therapeutic EUS.
ERCP has obviously been around a long time, like 50 years. I'd love to hear your perspective on how that has changed.
Well, I think it's obviously gone from more of a diagnostic to mainly therapeutic type procedure. But it's interesting, I think in the past 10 years or so, we're swinging back to look at diagnostics and how we can use that, how we can grow and expand that area as well. So I think that's kind of another area of expansion in ERCP right now.
Right. So a challenge, obviously, in ERCP is gaining and maintaining access.
Yeah.
So I would love, I'm sure the doctors listening would love whatever clinical pearls you have on those two things.
Gaining access, I guess, starts with a good examination of the ampulla. I always try to get my fellows to pause. They're so excited to get started. I'm like, just stop and look at the ampulla. Try to figure out where your biliary orifice is. But, I think some of it has to do with patient positioning. The majority of my procedures in the supine position, so that can be a little tougher, especially for a trainee. But it's appropriate positioning of the patient based upon whatever the clinical scenario is. Good examination of the papilla. Your devices and what you think might get you in. If it's a routine stone case versus a difficult malignancy or something like that, I have a variety of different tools.
Okay, and then what about maintaining access?
Maintaining access, I guess, depends on both you and your assistant. Keeping your eye on fluoroscopy, keeping your eye on your wire endoscopically. I think you have to be careful using your accessories and going in and out. But if you've gotten your access and you have fluoroscopic images with a cholangiogram, usually even if you lose access, hopefully you can get back in.
What is your approach for multiple stones in a duct?
Depends on the size of the stones. If they're small, you can do your standard biliary sphincterotomy, and I just, may opt to use either an extraction balloon or basket, depending on how it looks. Sometimes I use a basket actually in that situation. I start pretty distally. I don't want to go up too high and try to take out too many at one time. So I start with just, one or two towards the distal aspect of the duct. If you have large stones, I do routinely do a sphincteroplasty. I think that gives you better results.
And when are you deciding on the basket? I feel like when I was in the field, doctors were always more afraid to use the basket.
Yeah, I know. I guess it has to do maybe with how you trained. I don't know. But a lot of times, even with a really, with a complete biliary sphincterotomy, when you're yanking stones out with a basket, you'll get a tear of the apex of the sphincterotomy and, may have some bleeding or maybe you have some separation, of the mucosa from the duodenal wall. So I don't see that as much with a basket. So I do opt for that sometimes.
What about SPY and EHL or laser, or using that technology?
Yeah, absolutely. I mean, sometimes when you have large stones, you've got to go in and fragment it. I do sometimes use mechanical lithotripsy too, tends to be, late on a Friday night where there's only one nurse who knows how to do it with us. But, I'll opt for that sometimes. A lot of times we go directly to SPY. And I think it depends on what's available at your institution. What's readily available in my room is EHL, so I usually start with that first. But sometimes these stones are big, hard marbles, and we'll do better with a laser.
That's the determination if you pull the laser?
Yeah.
Okay. What about managing strictures? What's your algorithm for that?
Well, I think strictures, first is the diagnosis, which can be a bit challenging. And, when I said earlier that I think the diagnostics of ERCP are evolving again, it's mainly with stricture diagnosis. So we use cholangioscopy to characterize it and try to figure out, what is the endoscopist's impression of what's going on, because I think that holds a lot of weight, especially for someone who's experiencing cholangioscopy. You generally have a sense of what's malignant. And even if your tissue acquisition is not consistent with that impression, at least it can help drive you for continuing to try to get more tissue, or it may help the patient get to a surgical resection sooner, or at least surveillance imaging. So I think the impression of what you're seeing on cholangioscopy is very important. Certainly having consensus, on what we're seeing. There's a lot of different criteria that are going around right now. So trying to streamline that. But it depends exactly what's the scenario. I usually start out with an EUS in these patients, because if there's any way that I can try to get tissue, EUS, that's probably the most reliable. If there's, a regional lymph node or something that I could access, or a mass that will not be an issue in terms of, surgery down the line or anything like that, I usually try to get the majority of my tissue that way. Sometimes that's just not an option, or it's not safe, or it's just bile duct wall thickening. So we really have to rely upon ERCP to get tissue. So, of course, doing cholangioscopy, taking directed biopsies, I think that's usually sufficient. Sometimes in patients who, clinically, it really is an indeterminate stricture, in my opinion, and I'm not sure exactly how it's going to go, I'll take additional tissue, brushings for cytology or fish or something like that, less commonly.
Okay. On the directed biopsies, do you have a specific number you like to go for?
I take 2 bites. I always kind of laugh and say I'm lazy. I just want to take 2 and we'll see what we get. But I find with the newer SPY bite, we're really able to do that consistently. So I take 2 bites at once, and depends on how the tissue looks. I always ask the nurse or the tech in the room how my tissue looks, but at least 6 to 8 pieces.
A good number of passes.
Yeah.
And biliary RFA is obviously an emerging technology. So I'm curious how you've integrated Habib into your practice.
I do it for patients. One who comes to mind right now is I have a woman in her 60s who has a gallbladder cancer with biliary obstruction. And we ended up doing stent revisions and got her metal stents, and we did ablation. And just, she has a good life expectancy. She's doing well on chemotherapy. And, I want her to go as long as she can without having to come back. So, it's kind of the patient population that we target. I think in terms of therapy for bile duct strictures, RFA can really be implemented for a variety of different cancer types, so we have more of an option there as compared to others like PDT. I think if we can implement that into practice for the patient, it's good.
What's your treatment algorithm for Habib?
Depends on the location. I usually Usually in my practice, I've already stented that patient and I'm bringing them back. So most of the time I start with a plastic stent. So I'm taking them out and access. And then I start at the proximal aspect of the stricture. And then, we'll do sequentially down the duct as I see appropriate based upon the length of the stricture. Of course, we usually do balloon sweeps in between to get rid of some of the necrotic tissue and then re-stent.
And then when you're stenting a patient, how do you determine what stent, whether you're using plastic or metal or covered, all those different things?
That's a loaded question. And I think there are many long papers written on all of those subjects.
There are.
I think, starting out with benign indications first, really depends, I think, on what's going on. It's stone disease in someone with a very large duct, I'll opt to usually put double pigtail stents in. If it's somebody who be just a benign Moritzi syndrome or something that's very temporary, place a straight plastic stent. More complex scenarios, benign refractory strictures, I'll opt for metal stents. Sometimes I do that right away up front. Post-surgical patients who have strictures, a lot of times I'll go right to metal stenting in them. They've developed an anastomotic stricture. In terms of malignancy, that can be a little more complicated, I think, depending on if the patient's a surgical candidate and depending on your institution surgeons and what they're comfortable with. I mean, ours are very comfortable with metal stenting. So, if it's my impression that, I've diagnosed the malignancy and I'm clear on what's going on, I go right for a metal stent. Rarely do I use plastic in those scenarios if it's a distal or mid stricture. If it's a hilar stricture and complex, it depends on, I think, the size of the duct and degree of dilation. But I would say typically I usually start with plastic because in those patients it may be a little less clear exactly what their treatment plan is going to be. Mm-hmm. And so I think it's better, I usually have a multidisciplinary discussion between hepatobiliary surgeons and oncologists. I establish their treatment plan, and then I usually will go back in for a revision to give more definitive drainage and talk about treatment options.
I know a huge topic is how to prevent complications. So I'd love to hear what your algorithm is for that. What are you doing to prevent pancreatitis, for example?
So post-ERCP pancreatitis, I think there are a few things to talk about. Procedural, we give indomethacin. And generally, I think the ASG recommendations are to give it to everyone. And that with the patient's first ERCP, patients who are higher risk, I'm always administering it. I think in some institutions, having a lot of issues now with the cost of the medication. And, if you're in a large hospital system, they may be making suggestions about really trying to select the patient population who should be getting this medication. So I do routinely give indomethacin before the first ERCP or in higher risk patients. There are algorithms out there for aggressive IV fluid hydration, which is probably a little easier to apply to inpatients pre-procedurally and up to 8 hours afterwards, but maybe not as feasible with outpatients. I do give them a good amount of fluid in the PACU. And, I think wire-guided cannulation over contrast injection alone reduces the risk of post-ERCP pancreatitis. And of course, final thing is if you're accessing the pancreatic duct with a guide wire, if you're there a couple times, just go ahead and place a PD stent.
I wanted to shift gears. I wanted to ask you a couple questions about being a woman in therapeutic endoscopy. But before I do that, I just wanted to see if you had any closing thoughts you wanted to add about ERCP.
ERCP it's one of the best and most rewarding procedures. I think every interventionalist loves ERCP, loves pus drainage. We love the wires and all the devices.
Pus drainage.
Everybody loves pus drainage. It can also be, very frustrating and humbling procedure. And I think, what I love about it is the challenge. You never know what you're getting into. Be a straightforward stone case and be a nightmare to cannulate or whatever. So it's always a challenge, and that's what I love about it.
Okay, I love that. There aren't that many women, especially in advanced endoscopy therapeutics, and you have successfully built your career and built a family. And so I'd love to hear your thoughts on that, because if there's a woman who's looking at endoscopy or maybe advanced therapeutics but thinks there's just not a way to balance all this, I figured you might be able to give some advice to them maybe.
It's a challenge. I want to say I'm doing it successfully. I hope. It's hard to have it all. It's very difficult, and you sacrifice things along the way. Sometimes it's family, sometimes it's work. You have to kind of pick your priorities every day. I think the main thing is to say it takes a village is an understatement. I have a village at home and I have a village at work. At work, I have the luxury of having a lot of support in terms of PA support, fellow support, researchers, secretaries and administrative staff. So that allows me to focus not only on my clinical practice, but also as I take on administrative roles. I've learned more and more that if one of them isn't there, I can't function without them. So become really reliant upon your staff. It's not me, it's an entire team. I think that's very important to acknowledge. I can't do it without all of them.
Yeah.
It's the same thing at home. My husband is a special guy for putting up with me, certainly, how it works. He's also a physician, so I think he understands dedication and I don't even know what is the word, just the responsibility that we have for our patients. I think he sees that in me and understands it. So it's something I don't have to explain. But he has, really great hours as compared to me. So, he's home, and during the week, he takes the responsibility of kids, homework and all of those things that I just kind of can't do. I have a full-time nanny who's with me 7 to whenever we need her. She's been with me 8-9 years at this point, so she's really family. My in-laws are like second tier, in case my nanny's not there, I have my in-laws. And then, as your kids start getting older, and mine are almost 12 and 9, things start shifting a little bit. They want to be with their friends more, and perhaps that makes it a touch easier for me. But I think all of the mothers in my community, working mothers, non-working mothers, every mother's working, for the record. It's a really warm community. We have, have so many carpools. I am the carpool queen, and those moms pick up the slack. We do it for each other. I have one day, my admin day, I try to get out at a reasonable time, and I'm the carpool person that day. I may pick up my work afterwards, late in the evening, trying to catch up because I left a little earlier. But I show up. I make sure I show up at the most important things. And on the weekend, I'm 150% mom when I'm not on call, and I think it gets easier as your children get older and they accept what you're doing, and try to teach my kids, especially now that they're getting a little bit older, they need to focus on other people and what's going on and a little bit less on themselves. And I share with them sometimes what I'm doing at work. Call me all the time, sometimes in the middle of a procedure, and I explain to them, well, I have a sick patient on the table, with a cancer. I want you to be respectful of what I'm doing right now, and that I have to take care of that patient. And I think it teaches them a little bit of something.
It sounds like, if I had to summarize what you just said, it's like you have to be not afraid to ask for help.
Yes.
And really enlist a lot of different people. I had a nanny for 7 years, and we called her our nanny elf because she really was our lifeline. And then marrying the right person, because I think that having that help at home is so critical. You had some mentors over the years that have helped you with all of this, especially since you're more on like the groundbreaking end of this.
I would say I had 2 main mentors in my career, one of whom, although was a therapeutic endoscopist and the one who rescued me from motility, he taught me how to be a good doctor. And I spent a lot of time following him around, I was enamored with everything he was doing endoscopically. And being, part of his team, I would say, I inserted myself as part of his team. He held me to a higher standard in terms of caring for patients and the expectation and what he wanted to know about the patient. So many times I was sent back to get more information or whatnot, but I think he really taught me how to be a good doctor. It's interesting, when I came back from my training and I was in practice for a few years and I joined back at the same hospital, we have daughters the same age. And so I remember telling him I was pregnant. I was nervous to tell him. I had just gotten my advanced endoscopy fellowship, and I was not sure how that was going to go across. And he was so completely supportive. And then, interestingly, like a month or two down the line, he announced that his wife was having a daughter. And so it's been interesting seeing our kids who grew up, especially early on, as friends, and seeing him as a father, despite traveling so much, despite working very long hours. His daughter was certainly the apple of his eye, and to see him starting to set some boundaries in terms of need to leave today and show up at her concert or whatever. Seeing a man do that felt like I had permission to do the same thing, because I think sometimes as a woman you feel that you can't show that side of yourself, and so he, for me that was a little bit liberating to see him doing it.
Yeah, I love that. Well, this has been awesome, and I really thank you for coming and joining me today.
Thank you. It's been a real pleasure.
Thanks for listening to this episode of EndoCast. Please subscribe to the podcast and follow Boston Scientific Endoscopy on our Twitter, YouTube, and LinkedIn feeds. You can also visit our virtual education platform, EduCare. That's edukare.bostonscientific.com, and choose gastroenterology. The site features over 180 resources, including physician-led educational videos, lectures, case studies, device training videos, procedural tips, and techniques. Thanks for listening. EndoCast listeners, an important disclaimer. These materials are intended to describe common clinical considerations and procedural steps for the use of reference technologies, but may not be appropriate for every case or patient. Decisions surrounding patient care depend on the physician's professional judgment in consideration of all available information for the individual case. Boston Scientific does not promote or encourage the use of its devices outside of their approved labeling. Case studies are not necessarily representative of clinical outcomes in all cases, as individual results may vary. Thank you.